Let's move on to a question. A woman from a First Nations reserve in western Alaska presents with cough with flecks of blood in her green sputum. She has a 3-month history of fatigue, weight loss, and poor appetite. Her sputum is identified with Mycobacterium tuberculosis. There has been one historical case from her reserve without resistance patterns. The appropriate course of action would be A. Initiate isoniazid, rifampin, pyrazinamide, and streptomycin. B. Initiate rifampin to treat for 9 months. C. Initiate isoniazid for 18 months. D. Initiate isoniazid, rifampin, and pyrazinamide. If the organisms are fully susceptible, pyrazinamide can be stopped in 2 months. Or E. Initiate pyrazinamide for 18 months. Okay, you chose D, and that's correct. Now, this is a hard question, but let's just go through it so that you understand the concept. And when you go to the exam, you'll feel much more confident answering these kinds of questions. So in areas with less than 4% resistant to isoniazid, a 3-drug combination is actually reasonable. Now, the questions on TB will not focus on your intimate knowledge of each of the drugs, but on the uses and indications. If the patient had come from, say, an area of high endemic resistance, like South Asia or Southeast Asia, Somalia, or China, a 4-drug regimen is appropriate. Now, some people are advocating a 2-drug approach with just isoniazid and rifampin for 9 or 18 months. This is not unreasonable and could be correct. But the reality is that we use a 3-drug combination in almost all cases. So if you're caught with a question that gives you this choice and no other, then the 2-drug approach would be the answer. But in most cases, you're going to be given an option for a 3-drug approach, and that will probably be the right answer unless they specifically mention resistance. Single drug treatment of active TB is never a reasonable choice on exams or in the TB clinic. Now, let's go on to the next question. The woman from question 1 received the appropriate treatment. As part of the regimen, the CDC consultant also added pyridoxine or vitamin B6 to her regimen. What was the purpose of pyridoxine? Now, if you're not sure what the first question was, it's just dealing with a woman from a reserve in Alaska who was found to have TB in the sputum. Let's take a look at our choices. Pyridoxine will reduce the risk of pulmonary scarring during treatment. B. Pyridoxine will reduce the risk of hepatotoxicity during treatment. C. Pyridoxine will reduce the risk of dental erosions during treatment. D. Pyridoxine will reduce the risk of arrhythmia during treatment. Or E. Pyridoxine will reduce the risk of neurotoxicity during treatment. And the answer, of course, is E. This is a third question in a string of 2. The woman from question 1 was on oral contraceptives. If you've lost the first 2 questions, just be aware that she was started on a 3-drug regimen for TB, and she lives on a reserve with no worrisome resistance patterns. She does not wish to get pregnant. Which drug is most likely to interfere with the oral contraceptive agent? Is it ethambutol, isoniazid, rifampin, pyridoxine, or pyrazinamide? Good for you. You chose rifampin. Now, rifampin is an important thing to think about because rifampin is the prototypical cytochrome inducer, and it is the drug that we talk about when we're talking about multi-drug interactions. So rifampin is going to be the answer in that case. Let's go on to the next question. A 36-year-old HIV-positive male is tachypnic and hypoxic. His chest X-ray shows right middle lobe infection. He was diagnosed with Mycobacterium avian complex, or MAC. The appropriate treatment is one of the following. Is it A, clarithromycin with rifabutin? Is it B, azithromycin with rifabutin? Is it C, isoniazid with rifabutin? Is it D, azithromycin or clarithromycin with ethambutol and rifabutin? Or is it E, ethambutol, streptomycin, rifampin, isoniazid, and penicillin. Good. You chose D. You can choose either azithro or clarithromycin with ethambutol and rifabutin as the second and third agents in the treatment. Mycobacterium avium complex, or MAC, was actually first described as Lady Windermere syndrome. Now, who is Lady Windermere? She was a character in Oscar Wilde's play. She was one of these very proper people who wouldn't cough or wouldn't expectorate. And actually, it was surprisingly common in these women to see right middle lobe pneumonia because they didn't cough up the junk that was in their lungs. MAC made a comeback in the post-AIDS era. It is treated with a 3-drug regimen that includes a macrolide, ethambutol, and rifabutin. Infections from other bacteria, like Mycobacterium ulcerans or Mycobacterium marinum, are treated with similar drugs or other antibiotics, but are usually not a horribly symptomatic disease. That's it. You completed a very tough section. I'm really proud of you. Now go out to that exam and show them what you know.